So, moving on according to the agenda, the eighth talk is the use of neurostimulation methods in treatment of patients with cardiovascular diseases and atrial fibrillation. Professor Yakovlev, Moscow, Russia, Medelect clinic head, please share your knowledge with us. Yes, indeed, dear colleagues, good afternoon. Thank you for the opportunity to talk before this wonderful audience. I'm a neurosurgeon by background. Functional neurosurgery is my field. So when I started delivering talks at cardiological congresses, say 5 years ago or so, my topic was quite limited. I mean, quite limited interest. Arrhythmologists, cardiologists. I remember the first lecture was attended by 2 or 3 people. Now, in St. Petersburg conference, just 5 years later, there were 2 separate sessions dedicated to functional neurosurgery, which is to suggest that there is a higher interest from clinicians. The manufacturing companies have come up with new technologies that I will get to mention in my talk. Well, first of all, what is functional neurosurgery? Well, this area is using minimally invasive methodologies, particularly neuromodulation, the traditional resection destructive therapy, surgical destruction. All major surgeries come with certain downsides. There are several issues that I've put on this slide. It's not just for neurosurgery, it's for general surgery, any surgical field out there. So rejection and destruction, it's long duration, traumatism, high level of trauma, high risk of complications. The efficacy is limited by 50–70%. Contraindications are sometimes there, and its irreversibility. What you've cut off, it's very impossible to bring back to life, to suture back on. So if you're talking about urgent surgeries on spinal cord, it's quite low efficient. The efficiency is quite low. So the issue, the complications are 30–40% and higher. The overall surgical complications for spinal cord, even for the spine, I mean, death 0.2%, 1.5% infection, even higher. Deep vein thrombosis, DVT 3–7%. PE, pulmonary embolism 2.2%. When patients end up in ICU with a serious 50% plus nerve damage, there is also rejection of grafts. LACE methodology came up. This is a very interesting mild procedure for patients with mild stenosis that helps save patients' lives and extend their lives. What is neuromodulation? This is the main direction, which is now developing functionally. Functional neurosurgery, functional neuromodulation. Cardiology and arrhythmology, there are novel developments there. We used to know about electrical stimulation, but I will talk about targeted drug delivery. The companies, the manufacturing companies are well known. Our technology is similar to Medtronic pacemaker defibrillator technology. The company was founded in 1949 in Minneapolis suburb. Medtronic has grown to become a huge international giant. Spinal stimulation is most frequently used in functional surgery. It is the easiest one, no anesthesia, minimal mortality. The electrodes that are implanted on the CR Normally, we implant 2 electrodes to get the best effect and then reprogram the signal. If there are any mechanical problems, spinal delivery of drugs, this is the technology that helps reduce the dose of the drug from 100 to 300. I mean, the drug is delivered exactly to the target receptors, much higher bioavailability. So the drug is getting through the blood-brain barrier. You don't have to take, or people don't have to take pills with too much stuff and side effects when there are liver transformation of the drugs. You see the converted doses. Oral morphine, 300 milligrams per day. Intrathecal morphine, 1 milligram per day. So for baclofen, it's 100% reduction. The founding fathers of this therapy were American surgeons, James Corning and Rudolf Matus, late 19th century, New Orleans. Then the technology was developed by August Beer, a well-known surgeon and anesthesiologist back in late 19th century. In 1980s or in late 1970s, the first devices came up that helped treat oncological pains by intrathecal morphine injections. Medtronic technology emerged in 1991. It helped the first programmable pump called Synchromed. It gave the opportunity for non-invasive correction of pharmaceutical doses using the external programmator. The technology kept evolving ever since. It has become a reliable and convenient way. However, there are more and more patients with arrhythmias, with heart conditions, other heart conditions, regardless of the numbers of medications that are available for use. Statins, various effects from these pharmaceuticals are also, patients taking these pharmaceuticals end up in neurological clinics, in particular with various forms of neuropathies. Also, these patients, many of these patients, are coming from the fast food industry, so-called victims of the fast food industry. And basically, some of the pharmaceuticals simply give no help, or are no help for them. Revascularization, PCI or CABG, it's mostly catheter, percutaneous intervention, or the use of CABG, coronary artery bypass graft. Basically, these have been optimized using drug-eluting stents. You can use the off-pump technique, but these technologies have evolved to the pinnacle. They have reached the top, as you can see in this slide. There's been an active search for the past 30 years, what can be done and what can be offered to patients with ischemic heart disease. All of us know that even angioplasty, even catheter technology, 1 to 2% mortality. This is a routine figure, or that's a routine use figure. The death, depending on the situation, might reach as high as 6%. I just know the Russian statistics on that. The cath lab complications are listed in this slide. Well, most of all, it's dysrhythmia, it's ischemic complications, renal dysfunction and renal failure, and so on. Contrast-induced trauma. For CABG, it's death, which is quite high, around 3%. Arrhythmias up to 60%, renal insufficiency, and the number of neurological complications. In 1998, there was an article published in Circulation, the American journal. Two groups of patients were compared, CABG and spinal cord stimulation, SCS. The clinical results were quite close, but the SCS group presented much lower mortality and non-fatal morbidity and total morbidity. We are using SCS more and more over the past 2 decades. So what are the SCS effects in myocardial ischemia? Well, they're quite well studied. However, more and more articles are coming out showing various new findings. Well, first of all, the decreased myocardial oxygen demand, there's improved myocardial perfusion. Cardioprotective action of calcitonin, gene-related peptide, ADM, nitrous oxide, and beta endorphin. I would like to highlight not just the neurostimulation, but also the use of epidural analgesia anesthesia on refractory angina pectoris patients with IHD. This methodology can be used in patients who are candidates for revascularization in the future. We know that up to 30% of patients with a history of CABG, 1 year on, 1 year post-op, they start experiencing angina pectoris symptoms again. The angina comes back. For which reason? There's another technology that has come up. This is a Swedish article. The use of dosed local anesthetic delivery. Subcutaneously tunneled epidural catheter. The patients can use the drugs themselves, which helps improve their functional activity, which helps boost their life quality after all. Ventricular arrhythmias treatments. That area has an extensive experience of using surgical methodologies. There are minimally invasive methodologies that have come out, such as stellate ganglion block, cervical vagal stimulation. More and more methodology is coming up. Has been coming up ever since. So this is the stellate ganglion block, which helps patients with ventricular tachycardia they can live through the acute period. They can be transferred to the cardiac centers. There's a lot of information in the literature suggesting that these patients can live for quite a long time without any cardiosurgical methodologies on the just on this therapy alone. The literature involves quite a lot of information about the use of electric storm technology. This is what the thoracoscopic sympathectomy looks like. Until these days, RFA of the pulmonary veins, pulmonary vein isolation was used. Unfortunately, this methodology causes a lot of issues, causes a lot of questions. After the publication of the article, a multi-center Cabana trial, it showed that in some category of patients, this approach, well, basically the statistics is similar to those patients who still continue optimal medical therapy, optimal drug therapy. Unfortunately, all catheter technologies, including ablations, are not complication-free, and they can also become lethal. I mean, mortality is not zero, clearly not zero. So, enhanced stimulation using special systems, implanted devices like this slide shows have come out. Now there are new manipulations that have been developed, endovascular ablation of the right greater splanchnic nerve, which is reducing the efficiency, the activity of the sympathetic nervous system. You can hear me, right? Yeah, yes, we can, but the sound is really poor. Okay, so what we see there is the reduced activity of the sympathetic nervous system. There is a restoration of the volume of the vessels of the abdominal organs and decreased preload and improved left ventricular function. Endovascular baroreflex amplification, baroreflex amplification, and carotid body modulation. Stenting technology with elongation of the vascular wall, or dilating the vascular wall, which reduces the sympathetic nervous system activity. This is the new method, the new methodology, fairly promising one, fairly promising tech, using the transvenous stimulation of diaphragmal nerve. Patients can be treated by cardiologists, arrhythmologists. 77% of patients with sleep apnea, with OSAS particularly, with CSF, they have heart failure, reduced ejection fraction. Essentially, this technology involves implanting electrodes. One is sensing, one is stimulating. So the sensing lead and the stimulation lead. The function is reducing arrhythmia and expanding lifespan, or improving lifespan, prolonging life. Acceleration of blood is reduced, CO2 reduction, CO2 concentration is reduced, respiratory function is improved because of that system. In the recent couple of years, there have been publications, particularly in the Russian literature. There was the first domestic experience of treating the patient with atrial fibrillation. So the doctors actually use continuous spinal cord neurostimulation. That patient with a number of cardiological centers, medical therapy, radiofrequency we use cardioversion. Unfortunately, she was unable to come back to steady sinus rhythm. It was a chronic AF. At the time of admission from a neurosurgery center to our clinic, we still not accepting symptoms. After the test, we implanted two leads, upper, lower spinal cord sections, cervical, thoracic section of the spine. We were able to remove spinal stenosis symptoms, and we also brought back the sinus rhythm. For the past 5 years, the patient has been doing well. She's able to engage in professional activity. She has been on sinus rhythm. At the time, she was actually using a wheelchair. Lower limb edema because of apnea and quite a bunch of very nasty symptoms. We've been able to treat just by this. There are also broader experiences. Unfortunately, this is a retrospective article. Treating patients with concomitant cardiological, neurological pathology. For patients, very poor condition initially, sinus rhythm as an outcome. This is another work, Alexander Romanov. It's basically a prospective trial, looked at the group, 26 patients in the control group, and 26 patients in the SCS group. So half the patients received heart surgery, CABG. The stimulation was 3 days before and after the CABG, using the lead groups. The group with electric stimulation had very good results. Only one patient experienced a recurrence of AF, but it was well controlled. It's in line with the so unfortunately the sound is really poor, so I'm just getting isolated words there. So it's a life-saving method. The implantation of the lead is done for the cervical the lower cervical part, C7 to thoracic 4. There are no complications related to surgical part in SCS patients. The stats were completely amazing. I believe this trial has precipitated further works. It has paved the work for further research, for further trials that will improve the outcome for these patients with coronary arteriosclerosis, particularly patients who are eligible for CABG. Because right now the morbidity and the lethality post CABG, well, it's quite a bit of a burden for both cardiologists and cardiac surgeons. If that statistics is improved, well, it's really going to revolutionize cardiosurgery. So what are the prospective indicators for spinal stimulation? X syndrome with peripheric atherosclerosis of heart vessels. Professor Romanov, whom I cited, have used that in his work. So basically, combined use with CABG surgery in patients with high surgical risk is a good use for this technology, and peri-op use in heart and lung transplant surgeries. Something about genetic conditions, electric pathologies, and electrophysiological pathologies. Spinal stimulation can also be used as an addition to GP or RFA in atrial fibrillation, and vagus form idiopathic AF, neuromodulation of the conductivity speed in the AV node in case of tachyform atrial fibrillation. So the future is clearly bright for this technology. Those experts who have mastered this technology, so have gotten the right skills, they will be able to use them successfully and develop the technology. Unfortunately, the sound has gone completely poor. I believe that in a couple of years down the line, we will learn a lot of new things. We have a lot of plans ourselves in terms of development of our toolkit. So should you have any questions, I will be pleased to take them now. Thank you.